Good morning, doctor. I would like to discuss Ms. Pearl's case with you further and discuss additional testing and intervention that we can complete prior to her discharge, especially given her history of 2 prior preterm births. Although her bimanual exam shows her cervix to be long and closed, I would recommend considering completing a transvaginal ultrasound to check for cervical length. If Ms. Pearl is having more than 6 contractions in 60 minutes and cervical length is less than 3 centimeters, then she should be considered in preterm labor and further interventions should be completed to prevent preterm birth. If her cervical length is between 20 and 30 millimeters on ultrasound, I would recommend completing a fetal fibronectin test. And if positive, then she should be considered in preterm birth and should have further intervention prior to discharge. While awaiting the results of initial workup, I would recommend placing Ms. Pearl on a monitor for fetal heart rate and perform a non-stress test. I would also recommend evaluating for other conditions that can cause contraction symptoms by checking lab testing such as a CBC, complete metabolic panel, lipase, ALMase, urine culture, and possibly a chest x-ray if she's having respiratory symptoms to rule out pyelonephritis, UTI, appendicitis, cholecystitis, and pneumonia. I would also recommend checking a thyroid panel to rule out thyroid storm, as well as a GBS, and consider STI testing if Ms. Pearl is at higher risk. After initial workup, Ms. Pearl is found to have a cervical length of 28 millimeters and a negative FFN test. I would recommend that we continue to monitor Ms. Pearl for 4 to 6 hours to ensure no progression of contractions. After monitoring Ms. Pearl for 4 to 6 hours, she shows no progression of cervical dilation and effacement. Her lab testing has returned and the workup is unremarkable. This makes preterm labor less likely, and given her history of 2 previous preterm births, I would recommend administering beclomethasone 12 milligrams via IM over 24 hours apart, so 2 doses. And I would recommend magnesium sulfate for neuroprotection, which should be given as a loading dose of 4 grams and then 1 gram per hour for 24 hours. Once the therapy is administered and the patient continues to show no signs of progression, then she can be discharged home with close follow-up in 1 week. There is little evidence to support the need for daytime bed rest. There is actually an increased risk for blood clots related to daytime bed rest. So instead, I would suggest recommending avoid heavy lifting more than 20 pounds, limit excessive exercise. If Ms. Pearl has a low impact job, it's okay for her to return to work, as long as she does not work more than 40 hours a week, or is in a standing position for long periods of time, or working night shift. I would also recommend that she avoid sexual intercourse if cramping or contractions occur. Lastly, I would not recommend long travel to ensure prompt access to care if needed. Of course, if there's any signs of progressing preterm labor or new symptoms present, I would recommend Ms. Pearl return sooner than her 1 week scheduled follow-up. Do you have any additional thoughts or recommendations on this plan? Thanks for your time.